Coming to the second part of endocrinology. Now, in the second part of endocrinology video, we'll be studying about the corticosteroids and gonadal hormones and the drugs which are affecting the calcium balance. So these are the three main topics that we'll be covering in this video. Now, adrenal gland, we all know that it consists of two parts. That is, one is medulla and one is cortex, right? Now, medulla mainly secretes adrenaline, while the cortex is the one which secretes glucocorticoids and mineralocorticoids. Okay. So now let's take the mineralocorticoids first, right? Now in mineralocorticoids, what we have? Aldosterone. Aldosterone is the prototype or the endogenous mineralocorticoid. Now aldosterone, basically action of aldosterone is that it saves sodium and water, right? Or reabsorbs sodium and water and removes potassium and hydrogen ion. Okay, so this is the action. Now, and here in the collecting tubule, if you have seen this, there is this transport protein, which basically, if this is blood and this is cell and this is lumen, so there is movement of sodium ion towards the blood and potassium ion towards the urine. So potassium ion is excreted, similarly hydrogen ion is excreted and sodium ion is saved along with water, and this is potentiated by aldosterone receptor or aldosterone. Okay, so if we have excess of aldosterone, as in there is more of aldosterone, then what will it cause? It will cause hypokalemia, because it is throwing potassium outside in the urine, and it will cause metabolic alkalosis. Okay, and in Addison's disease, which is basically the deficiency of aldosterone, so in Addison's disease it will cause hyperkalemia and metabolic acidosis. Okay, and along with that there will be hyponatremia also, because sodium will be lost in the urine. So this is the generalized physiological features which are seen with the hydrocortisone. Okay, now let us see what are the other effects of aldosterone. So on blood, it is seen that it destroys T cells and B cells, right? It increases lymphocytes, basophils and neutrophils. These I am saying about the actions of glucocorticoid. Sorry, I'll mention here, we are talking about, this was aldosterone, this is glucocorticoid, and in glucocorticoid, the endogenous glucocorticoid is hydrocortisone. Okay, so talking about hydrocortisone on blood, this is the action. Then what is the action on inflammation and immunity? It basically reduces the chemotaxis. It is anti-inflammatory. Okay, reduces the mediators, prostaglandin, thromboxane A2, reduces leukotrienes. Then it also suppresses cell-mediated immunity, right? So it reduces the recruitment of immune cells, right? So that is the effect on blood. Then there are some metabolic effects. Metabolic effects mein corticosteroids, they cause hyperglycemia, they cause muscle wasting, and they cause a redistribution of fat, right? Then they cause osteoporosis, they basically cause a negative calcium balance. Then in CNS, they lower the seizure threshold and can precipitate epilepsy. So these are the basic effects of glucocorticoids. Now let us go to the classification. Now classification is very important to understand, because यहीं से सारे questions जो corticosteroids के हैं वो काफ़ी सारे questions यहाँ पे बनते हैं. So the first category is short acting glucocorticoids, which are less than 12 hours. Here we have the main drug is hydrocortisone, right? And this is a glucocorticoid with maximum mineralocorticoid activity. Okay. Then we have intermediate acting, which are 12 to 36 hours, and in this we have prednisolone and methylprednisolone and triamcinolone. उसके अलावा there is a drug which is called as deflazacort, right? Now this triamcinolone is a selective glucocorticoid. Deflazacort is a selective glucocorticoid. It has got no mineralocorticoid activity. It is used in pediatric patients, and it is the drug of choice in Duchenne's muscular dystrophy. Okay, so this is deflazacort. Then we have long acting, right, which are 36 to 72 hours long, and in this we have dexamethasone and betamethasone, and dexamethasone is the one which is having maximum glucocorticoid activity. Then betamethasone is again having a maximum glucocorticoid activity, right? Then इसी में there are some more drugs. I'll take it on another page because here we don't have any space, but I need to come back to this part again. Then if I talk about mineralocorticoids, so in mineralocorticoids there is a drug which is called as DOCA, and this is a selective mineralocorticoid. Then we have aldosterone, which is maximum mineralocorticoid activity. Then we have fludrocortisone, which is mineralocorticoid with maximum glucocorticoid, right? So this fludrocortisone, it is the drug of choice in congenital adrenal hyperplasia and in Addison's disease. Okay, so now please remember, in mineralocorticoids, fludrocortisone is the drug mineralocorticoid with maximum glucocorticoid, and aldosterone is maximum mineralocorticoid, doca is selective mineralocorticoid. And here in this, you can see that dexa, beta are maximum glucocorticoids. Hydrocort is the glucocorticoid with maximum mineralocorticoid, and triamcinolone and deflazacort are selective glucocorticoids. Okay, so these are some drugs. If I keep them together like this, and you should be able to, but you can see the whole thing. So anyways, you will see it in the notes. So you please remember that these drugs are this classification is very important to be remembered. Right, now next we come to the uses. Now what are the various uses? So first is replacement therapy. Replacement mein what is there? Replacement mein we have acute deficiency, acute adrenal mineralocorticoid deficiency and glucocorticoid deficiency. So IV hydrocortisone is the drug of choice. Okay, and if there is a chronic, then you give oral hydrocort plus fludrocortisone. In congenital adrenal hyperplasia, what is there? There is basically increased ACTH secretion from the pituitary, but there is no glucocorticoid secretion, no synthesis, and as a result the gland becomes big in size, so there is a hyperplasia. So therapy, the target of the therapy is to reduce ACTH. And how do you do that? You do it by giving hydrocortisone plus fludrocortisone if there is salt wasting. Okay, so this is the first use of corticosteroids. The second use is diagnostic, that is dexamethasone suppression test. And dexamethasone suppression test is used to test the intactness of HPA axis and Cushing's, right, syndrome. So this is the diagnostic use. The third use of the corticosteroids is antenatal. Now antenatal use, it is used for fetal lung maturity, okay, to increase the lung maturity. How do they do that? They increase the surfactant, right? Now it is seen that betamethasone, it is given 12 milligram 24 hourly in 2 doses, and dexamethasone is given 6 milligram 12 hourly in 4 doses, and it is given intramuscular to the mother. So this is the antenatal use of dexamethasone in fetal lung maturity. Please remember these doses, they are very important. Let's come to the non-adrenal uses. Now non-adrenal uses में it is used long term. Non-adrenal uses इसके mainly immunosuppressant, anti-inflammatory, autoimmune diseases. So these are the main uses which are non-adrenal in infections, in diseases, in cancer, in chemotherapy, bronchial asthma, status asthmaticus. So these are the uses. Long-term uses में more than 2 weeks, if you use them, then it will result in HPA suppression. So this has to be kept in mind. And what are the adverse effects of these drugs? They cause hypertension, edema, then alkalosis, then hypokalemia, right? Cushing's habitus, इस पेन की अब लाइफ खत्म हो रही है. Osteoporosis is an adverse effect. Ulcers, peptic ulcers, not to be given in pregnancy, not to be given in psychosis patients and epileptic patients because it lowers the seizure threshold. Then avascular necrosis of hip joint, it causes, right? So these are some of the side effects of steroids. Now let's see some drugs which are steroid inhibitor. Now steroid synthesis inhibitor, I'll say steroid synthesis inhibitor mein the drugs which we usually study in steroid synthesis inhibitor are amino glutathamide, then ketoconazole, then metyrapone, then oscillodrostat, then mitotane, trilostane, abirostane, sterone, right? So these are the drugs which are seen to have anti-steroid effect. Even mifepristone has got anti-glucocorticoid activity. Then spironolactone, and uska jo ek aur congener hai eplerenone and drospirenone. Okay, so these are some of the drugs which cause synthesis inhibitor of steroids. Now the next category of drugs that we are studying is called as calcitonin, and drugs which are maintaining the calcium balance, right? Now इसमें there is a thing called as vitamin D. So vitamin D क्या करता है? ये कैल्शियम बढ़ाता है, ये फॉस्फेट बढ़ाता है हमारी हड्डियों में, ये इंक्रीज करता है इंटेस्टाइनल एब्जॉर्प्शन, and ये reduce करता है renal excretion of calcium and phosphate, right? Then there is parathormone, and parathormone increases calcium and reduces phosphate. So it reduces the renal excretion of calcium and increases the renal excretion of phosphate. Then it increases the resorption of calcium. It increases the intestinal absorption of calcium. It increases the resorption of calcium from the bones, right? So this is the action of vitamin D and PTH. Then let's see osteoporosis. Osteoporosis में we use vitamin D and calcium for the treatment part, right? Now let us see PTH के लिए for parathormone, whenever there is a reduction in the calcium, a reduction in calcium will stimulate PTH secretion, and an increase in calcium will inhibit PTH secretion. So the stimulus to PTH secretion is a hypocalcemia. Hypocalcemia will result in increased parathormone secretion. Parathormone का effect, it increases the circulating calcitriol, that is vitamin D, right? So parathormone का effect ये रहता है कि ये calcitriol को बढ़ाता है. Vitamin D के different forms होते हैं. Vitamin D2 is called as ergocalciferol and vitamin D3 is called as cholecalciferol. Okay, so these are the various vitamins and related to the calcium balance. Now a very important part, because it will take a new page, so I'll better take a new page and I'll better change the pen also. So now let's see osteoporosis. Treatment of osteoporosis mein, what are the different modalities? Now there are drugs which inhibit osteoclast. Okay, there are drugs which will stimulate osteoblast, and there are drugs which will have a dual action. That means they inhibit the clast and increase the action of blast. Now in inhibiting osteoclast we have bisphosphonates, then calcium, then denosumab and estrogen. Okay, the drugs which will stimulate the osteoblast, in this we have drugs like teriparatide, then parathormone, and then we have SERMs. Okay, so now let's see these drugs one by one. The first drug which we'll see is bisphosphonate. Now bisphosphonates में the drugs that we have are alendronate, then risedronate, then zoledronate. Okay, now these drugs, they inhibit the osteoclast action. Okay, these drugs inhibit the action of the osteoclast. They are used for a period of 5 years, followed by a drug holiday period for 10 years. Okay, so these drugs are not given continuously, they are given for a particular duration, then followed by drug holiday. They are highly toxic to esophagus, and so it is very important to take them on empty stomach, full glass of water, and remain upright for some time after taking the drug. That is why you will find some clinical scenario type of question that why is the patient asked to remain upright. Clinical scenario question can be based on this. Now they are used, uses क्या हैं इनके? It is used in Paget's disease, and it is also used in hypercalcemia of malignancy. Okay, then zolendronate. Zolendronate is known to cause, it causes renal toxicity, it causes osteomalacia, and it also causes osteonecrosis of jaw. So these are the problems caused by these drugs, zolendronate specifically. Then we come to estrogen and SERM. Now estrogen and SERMs, these drugs, what they do is on the bone they prevent the resorption of bone. On the blood they increase the HDL upon LDL ratio. Breast में they cause increased risk of carcinoma. In the endometrium they cause increased risk of carcinoma. Liver में they cause increased thromboembolism risk because they increase the clotting factors, right? So these are the actions produced by the estrogens and SERMs. Now they are not preferred for treatment of postmenopausal osteoporosis because we have better drugs, that is bisphosphonates. Then raloxifene is the SERM which is used in the postmenopausal osteoporosis because this is agonistic in bone, blood and liver, and it is antagonist in breast and endometrium, right? ठीक है, अब इसमें कुछ न्यू SERMs हैं, that is bazidoxifene. This is used in postmenopausal osteoporosis. Additionally, it increases the HDL and it reduces the tendency of breast and endometrial carcinoma. A major side effect is thromboembolism, as we have seen earlier also. So these are the estrogens and SERMs. Okay. Next we have denosumab. Okay, now denosumab is basically, अब इसके पीछे की आप ये पढ़ो समझो. सबसे पहले तो ये होता क्या? This is a monoclonal antibody against rank ligand. Okay, तो होता क्या है that we have rank receptors on osteoclast, and this ligand is there, which is secreted from the osteoblast, and this rank receptor plus ligand, they do what? They activate the osteoclast and they result in the bone resorption. So this denosumab, it binds to the ligand, inhibits it, so rank receptor is not activated, and so the osteoclast is not activated. So denosumab is also found to be effective in osteoporosis. Then the next drug that we have is teriparatide and abaloparatide. ठीक है, तो teriparatide and abaloparatide ये क्या करते हैं? They basically stimulate osteoblast. Okay, now when this is a recombinant parathormone, so when recombinant parathormone is given in low pulsatile doses, then it actually stimulates the bone formation. Because see, parathormone क्या करेगा? Parathormone bone resorption कराता है. It causes increased osteoclastic activity, but according to the osteoclastic activity, it also causes osteoid formation, osteoid deposition, and causes bone formation. So the overall effect is bone formation of parathormone. So when we give teriparatide in low pulsatile doses, this is important. Low pulsatile mein it will stimulate bone formation. If you give in excess dose, then it will cause resorption of the bone. Okay, so it has to be given in low pulsatile format. So the teriparatide is given by subcutaneous intermittent subcutaneous absorption administration. Okay, now it is seen one more very specific feature, that on long-term use, they improve the bone mineral density in all the bones except distal radius. Distal radius की जो bone होती है उसमें bone mineral density ये नहीं बढ़ाता है, right? In high doses it can cause osteosarcoma. Then this has to be avoided in Paget's disease. Then it has to be avoided in prior radiotherapy, then past history of osteo or chondro, then osteosarcoma, chondrosarcoma, and also unexplained increase in ALP whenever there is this situation. Then it can be used in hypercalcemia with corticosteroids. It can cause hypercalcemia with corticosteroids and thiazides. Thiazides and corticosteroids hypercalcemia करते हैं, and उनके साथ में अगर ये देंगे तो it can cause even more hypercalcemia. Then after giving teriparatide, a course of bisphosphonate is always considered, right? What are the adverse effects? Adverse effects में आता है nephrolithiasis, and it also increases the serum uric acid. So this is about the teriparatide. Another parathormone, it reduces the calcium secretion in milk, saliva, and lens, and because of that it can result in cataract. Hypoparathyroidism. So hypoparathyroidism can cause cataract also. Okay? So this was about the parathormone. Now there are some more drugs in the same, some new drugs which are asked. So the first drug that we'll talk about is romosozumab. Okay, romosozumab is a monoclonal antibody against sclerostin, and this is given by subcutaneous route. इसके dual mechanism होता है. What is the dual mechanism? As it is a monoclonal antibody against sclerostin, so it inhibits osteoclast and it stimulates osteoblast. Then there is a drug called as sinacalcet. Now sinacalcet is actually calcium sensitive receptor. There's a calcium sensitive receptor and ये उसका agonist होता है. So this is present on the parathyroid gland. Now this calcium sensitive receptor, when it is secreted, when it is stimulated, when calcium is when CSR is stimulated, then it reduces parathormone, because this is an indicative of increased calcium. And when calcium sensitive receptor is inhibited, then there is an increased PTH. And why? Because this indicates that there is decreased calcium. So this is sinacalcet, is basically a calcimimetic drug, and it grows and attaches to this calcium sensitive receptor, and thus it reduces PTH secretion. Okay, now the first use, it is used in secondary hyperparathyroidism. Second, it is used in patients with hypercalcemia with parathormone, parathyroid carcinoma. Okay, then sinacalcet की ही तरह एक और ड्रग होती है eticalcetide. Now eticalcetide is a new calcium sensitive receptor agonist, right? It is used IV in secondary hyperparathyroidism with chronic kidney disease and patients on hemodialysis. So eticalcetide is a CSR agonist which is used intravenously in patients of secondary hyperparathyroidism with CKD and on hemodialysis. So this is the profile of patients on which eticalcetide is used. Then there is a new substance which is strontium granulate. Now this strontium granulate decreases the bone resorption and increases the bone formation. Okay, what it does is it basically incorporates into hydroxy apatite crystals, replacing the calcium, right? So this drug basically can be used in osteoporosis. Then the last drug in this category we just need to discuss, calcium is life-saving in hyperkalemia, in very severe hyperkalemia, when the potassium is more than 7 milliequivalent per liter. It is used IV in tetany. Calcium gluconate is given here. What is given? Calcium gluconate. Then calcium IV, it is given in black widow spider toxin, also given in magnesium toxicity, right? Then thiazides are given to reduce the renal stones, as they reduce the calcium excretion. So thiazides are maintaining like that. Then there is a compound which is called as calcitonin and calcitonin. Now these drugs, they are hypocalcemic. They are secreted from the parafollicular C cells of thyroid. They reduce the resorption of bone, and they are used in osteoporosis by nasal route. So this is about calcium and calcitonin, calcitonin. Okay, now next we'll take the gonadal hormones. Now starting with the last part of endocrinology, that is gonadal hormones. Now in this gonadal hormones, we are going to discuss about estrogen, then we have progesterone, and we will be discussing about androgens also. Okay, these are the principal gonadal hormones. Now let's start with the estrogens. So estrogens, the naturally occurring estrogen is called as estradiol. This is the principal gonadal estrogen hormone that is being secreted from the ovaries, and it is circulating in our system. The other ones are estrone and estriol, right? Now these are all natural, and natural estrogens hote hain, they are ineffective because of high first pass metabolism. Okay, so that is why we need to give drugs which are based on them, analogs. Then estrogens, they also undergo enterohepatic circulation, so they also can cause hepatic adenoma, and they also can cause thromboembolism. Okay, now let us see the effect of the hormones on various aspects of our body. So here, this is estrogen, this is progesterone. Now on the menstrual cycle, you will see that estrogen has mainly proliferative response, while progesterone has got a secretory response. Then on lipids, estrogens, they reduce LDL and they increase HDL, right? In this, they increase LDL and they decrease HDL. They also increase triglycerides. Then glucose they impair the glucose tolerance, while progesterone increases the insulin release. On fluid balance in our body, estrogens cause retention of sodium and water, and progesterone causes decreased sodium ion reabsorption. Then if we talk about thromboembolism, then estrogens, they increase the risk of thromboembolism because they increase the factors. Progesterone does not have any effect on thromboembolism. On breast cancer, on various cancers, so breast cancer, both of them have an increased risk. On endometrial cancer, or what we call as uterine cancer, estrogens increase but progesterones decrease the risk. On bone, estrogen decrease the resorption. Okay, progesterone does not have any effect. On bile lithogenicity, estrogen increase this tendency. Okay, so now coming to the uses. What are the various uses of estrogen? So it is used as OCP, as a component of OCP. It was earlier also used as a component of HRT, and in HRT, progesterone is added to increase. Progesterone is added to decrease the risk of endometrial cancer, because estrogen can increase the risk, progesterone decreases. They are also used in dysfunctional uterine bleeding or abnormal uterine bleeding. Now let us see what are the adverse effects of estrogen. So estrogen, if they are given in a young stage, they can result in feminization, closure of epiphysis, gynecomastia in males, decreased libido. They can also cause migraine, increased risk of cancer, and increased risk of gallstones, right? They cause diabetes, fluid retention. Then they also increase the risk of hepatic adenoma, right? Thromboembolism, polylithiasis. So these are all the side effects. Then they can increase the risk of vaginal adenocarcinoma in female offspring of mothers who have taken diethylstilbestrol. Then rifampicin, which is a component of ATT, antitubercular therapy, reduces the action of estrogens, and in a way they also reduce the action of OCPs. This we also have seen in the drug interactions, right? Now moving forward, there is a term which is called as SERMs. Okay, now SERMs are basically selective estrogen receptor modulator. They are agonist on some and antagonist on some other tissues, right? So इसमें जो हमारे पास drugs हैं in SERMs, we have the first drug, that is clomiphene. Now clomiphene, we all know it is basically a pure antagonist, and so it basically reduces the feedback inhibition of GnRH and results in increased secretion of gonadotropin release hormone, which results in increased FSH and increased LH, which results in ovulation. And so this is used in the treatment of infertility. So clomiphene is the drug which is used in infertility. It is a SERM. Then other drugs that we have are tamoxifen. So tamoxifen, we all know it is used in because it has got antagonist activity in the breast and it has got agonist activity in the bone, uterus, right? So it is used in breast carcinoma. ठीक है, so that is tamoxifen. Tamoxifen के बाद उसके दूसरी दवाइयाँ हैं डोलॉक्सिफिन एंड टोरेमिफिन. ठीक है, इसके अलावा जो रेलॉक्सिफिन है एंड बाजेडॉक्सिफिन है, they are used in the last calcium balance we had seen, they are used in postmenopausal osteoporosis, right? Now these drugs, tamoxifen, they have an increased risk of endometrial carcinoma and thromboembolism. These drugs also have an increased risk of thromboembolism. Then there is a new drug, that is ospemifene. Now this ospemifene is a new SERM which is indicated in dyspareunia due to menopause. So in females who are menopausal females, ospemifene is a new SERM which is used in this particular condition. Then we have a drug which is called as centochromine. Now this is basically a non-hormonal OCP. It is also approved for the treatment of DUB, right? Then there is another new drug which is called as Progesterone. Progesterone is an inactive steroid which is converted to estrogens and androgens, right? And it is indicated for treatment of dyspareunia due to vulvovaginal atrophy. So this is progesterone, right? Then there is a drug. Now SERMs थे, अब है SERD, that is selective estrogen receptor down regulator. इसमें जो दवाई आती है उसका नाम है fulvestrant, and this is the first FDA approved pure antagonist, and it is used in hormone positive metastatic breast cancer that has progressed despite anti-estrogen therapy. This is also effective in tamoxifen resistant breast cancer. Okay, so this is SERD, which is effective used in breast cancer. Then there is another drug that is called as STEAR, that is selective tissue estrogen activity regulator, and the drug which we study in this is tibolone. Tibolone is actually also called as designer HRT, and what does it do? It prevents vasomotor symptoms and osteoporosis in menopause. So this is the action of tibolone, right? So that is, tibolone is actually a steroid. अब आगे बढ़ते हैं तो नेक्स्ट अपन इसमें आते हैं. We have drugs which are aromatase inhibitors. ठीक है, aromatase inhibitors की बात अपन करते हैं. तो aromatase inhibitors दो जनरेशन्स होती हैं, फर्स्ट जनरेशन एंड सेकेंड जनरेशन. फर्स्ट जनरेशन में द ड्रग दैट वी स्टडी इज अमाइनो ग्लूटाथिमाइड. नाउ सेकेंड जनरेशन में देयर आर टू टाइप ऑफ ड्रग्स. वन इज स्टीरॉइडल irreversible, and then we have non-steroidal reversible. Okay, now steroidal irreversible में the drugs that we have are letrozole, anastrozole, fedrozole, and vorozole. In non-steroidal irreversible we have exemestane and formestine. So this is the classification of aromatase inhibitors, and these are again drugs which are used in prostatic carcinoma, in breast cancer, and they are found to be very effective. Aromatase, if you remember, aromatase is also the enzyme which inhibits the conversion of aromatase converts testosterone to estrogen. So that enzyme is also aromatase, right? Next we have progestins. Now progestins में देखो, progestins या progesterones, they are secreted basically endogenously by the corpus luteum, right? Now first generation होते हैं, इसमें आते हैं norethindrone, linesterol, ठीक है. Then second generation में आता है norgestrol, levonorgestrel. Then third generation में आता है desogestrel, norgestrel and gestodine. And then we also have a fourth generation in which we have nomegestrol and dosperinone, which is a minor aldosterone antagonist also. Now these progesterones, where are they used? What are their uses? They're again used as part of OCPs. They're also part of HRT. They're also used in dysfunctional uterine bleeding. Then there is a term which is जैसे sperm था ऐसे ही sperm है, that is selective progesterone receptor modulator. In this we have the drug which is mifepristone. Now mifepristone is a pure progesterone antagonist, right? So it basically it is used in medical abortion. So there is a dose 600 milligram of mifepristone plus oral misoprostol, which is prostaglandin F2 alpha, which is 400 microgram. So this dose is found to be effective in MTP, medical abortion. Okay, so this is basically mifepristone. Also has anti-glucocorticoid action, and it is also having androgen receptor blocker action. Okay, single 600 milligram is an effective emergency contraceptive also. Okay, then since it is anti-glucocorticoid, it is also can be used in Cushing's syndrome. Then next drug which we have is that is onapristone, right? Now this onapristone is a pure progesterone antagonist. Then we have a drug ulipristal. Ulipristal is a partial agonist on progesterone receptor. It does not block the glucocorticoid receptor, right? It can be used as an emergency contraceptive at a dose of 30 milligram, and that has to be taken within 120 hours of unprotected intercourse. Then there is another drug, Aspirants. This is an investigational sperm and it is under testing for progesterone sensitive myoma. Okay, so these are some more progesterone, anti-progesterone drugs, right? Next we go on to the hormonal contraceptives. Now hormonal contraceptives are a very easy topic, and usually questions based on this should not go wrong. Now hormonal contraceptives, mostly they are combined pills, right? Most common progesterone that we use is levonorgestrel. So combined pills mein there are biphasic and there are monophasic, biphasic and triphasic. So these are the pills, and we also have some mini pills. Then these mini pills, they basically cause the cervical mucus thickening. Then we have emergency contraceptives. They basically inhibit the implantation. Parenteral use भी दिया जाता है in females having a contraindication to estrogens. तो इसमें जो depot preparations होती हैं which are given either subcutaneous implants or intramuscular implants. So they give prolonged depot preparations are there, and what are they? We have Norplant and Capranol, which are given as subcutaneous, and we have DMPA and NET-N, which are intramuscular. Some side effects, if I talk about the side effects, adverse effects, then OCPs can increase migraine. With breakthrough bleeding is seen with the progesterone only pills, right? Then they can cause weight gain, venous thromboembolism, stroke. These conditions are increased. All the side effects of estrogens, cholestatic jaundice, gallstones, lithiasis, gallstones, liver, hepatic adenomas, they all are increased with OCP use. There's also an increased chances of breast cancer and reduced endometrial and reduced ovarian cancer, right? Now in OCPs, what are the non-contraceptive uses of OCPs? What are the non-contraceptive uses? Then we have ovarian cyst, benign breast disease, ectopic pregnancy, endometriosis, fibroids, then iron deficiency anemia, then any neoplasia can be used like endometrial or colon cancer. So these are some non-contraceptive uses of OCTs. The next thing that we come is discuss is androgens. Androgens. Now androgens we have two main androgens, that is testosterone and dihydrotestosterone. Now testosterone is converted to estradiol by aromatase enzyme that I have told you earlier, and it is converted to dihydrotestosterone by 5-alpha reductase. Okay. Now what are the uses? Now testosterone as such intramuscularly it is used in hypogonadism. Long term अगर oral लेते हैं तो it can result in increased liver adenoma. Then it can also be used in, it can cause polycythemia, hypertension. Then it is abused by athletes for their anabolic effect, right? Testosterone stimulate growth, and side effects are hirsutism, atherosclerosis, right? They can also cause cholestatic jaundice and peleosis hepatica. Androgens are contraindicated in pregnancy. Now there is a drug called as danazol. Okay. Now danazol is actually a weak androgen. It also has got progesterone and glucocorticoid activities. Danazol is used in endometriosis, and danazol causes hepatocellular damage. So now what are the drugs which are anti-androgenic in nature? Now see, most of these drugs are the same as anti-corticosteroid drugs. So in this we have ketoconazole, it has got anti-androgen action. Then spironolactone and eplerenone. Then abiraterone. Then we have 5-alpha reductase inhibitors, which is finasteride and dutasteride. And these drugs we had also discussed when we were discussing with the drugs which are used in BPH. So these drugs, they are used in prostate carcinoma. They are used also in BPH. Okay. Then we have androgen receptor blockers. So androgen receptor blockers mein we have flutamide, bicalutamide, and nilutamide. Right? These are the drugs which are androgen receptor blocker, and they also can be used in the same. Flutamide is also known to cause gynecomastia. Right? So these are the drugs which are anti-androgen in nature. Next, and the last portion in this is oxytocin. We have discussed vasopressin earlier. So the hormones of posterior pituitary, which consist of oxytocin and vasopressin. Oxytocin is remaining. Oxytocin secreted from posterior pituitary, right? And it causes contraction of upper segment of the uterus and relaxation of lower segment of the uterus. Okay. Now oxytocin is associated with milk ejection reflex. It is used to potentiate normal labor and also used in PPH as an alternative to methyl ergometrin and misoprostol. Okay. Adverse drug reaction caused by this can be rupture of uterus. Rupture of uterus is usually seen with methyl ergometrin because it causes very severe contractions. So they are not to be used in contracted pelvis, obstructed labor, malpresentation, LSCS, hypovolemia, and cardiac diseases. Okay. Now ergometrin and methyl ergometrin. This is more potent oxytocic than any other drug. It is the drug of choice to treat PPH, and it is delivered at the, or I'll say it is administered at the delivery of anterior shoulder of the baby. It is given intramuscular to the mother. Okay. Contraindications are hypertension or sepsis. Okay. So if I say about PPH, then the drug of choice is oxytocin also and methyl ergometrin or ergometrin also. Okay. Then misoprostol can also be used because this also causes contraction. And last, if the bleeding is not controlled, then we can use tranexamic acid also. So with this, we complete the endocrine system.